Thank you. I don't have a question at this time. Thank you for the presentation. I do want to let you know that when we come to the hearing where we talk about Cal HERES, I have a lot of interest, and I'm going to push. Okay. And I think I said it last year. I was really concerned that living in the state with the highest level of innovation around technology, that we still have systems that seem to not fully support our ability to enroll and manage cases and service delivery, and not just in this program. I think across so many, whether they be in health, whether it be on the human service side in CalFresh or child welfare systems. And I am not leveling blame, but I do think that we've got to figure out a way to get it done right. And so I'm letting you know that when we have the conversation, there are going to be a lot of questions for me and hopefully others on the committee. Okay. And I have a lot of interest in the subject. It does not help you any that I just come off of a full tour and site visit at Facebook, where, if we can do it there, we can do it here. And I know that the state of California spends a lot of money on technology. And to support these programs, it's just my expectation that we find a way to make them work so that we can enroll our citizens and avail them to the services that they are entitled to.
Great.
Thank you.
We'll be ready.
There you go. There you go. We like that. We like that. Thank you. Anything from finance? Anything from the LAO's office? Thank you. Any public comment?
The Oscars, that just raises automatically to your height. You guys should think. Thank you.
We're working on that.
Thank you, Mr. Chair. Kathy Sunderling McDonald with the County Welfare Directors Association, here to support the governor's budget proposal. We really appreciate the recognition of the ongoing caseload increase and the significant challenges that we continue to have with Cal HERES on the front line, as you noted, and as the Department of Finance and Department of Healthcare Services noted. We also really do appreciate the willingness to roll up the sleeves on the department's part and the administration's part and get in there and see what our workers are experiencing. I participated in those site visits, as did other CWDA staff, so we could also see what was going on, and we do think that this bears out what was seen. We really appreciate that. Obviously, we'll continue that conversation around Cal HERES and appreciate your comments, but please urge you, when you do take the vote, to support the governor's budget proposal.
Thank you.
Good afternoon, Mr. Chair and members. Tia Orr on behalf of SEIU California. We are here on behalf of about 20,000 eligibility workers across the state of California who stand committed in all of your districts to make sure that we serve all of those who need health care as best as we can. We are in strong support of the governor's augmentation. We think this is going to help us deliver the essential services that so many in your districts are seeking. Obviously, with IT problems continuing, the demand being so high, which is obviously great news, this is definitely going to help us be able to enroll as many Californians as possible. I would say that, we have some work to do moving forward with putting a workload study together, figuring out the exact number that we need to make sure that this continues moving forward. We also have a very detailed conversation that needs to be had about the Cal HERES system and how we fix the IT system so that, again, we can continue to help clients moving forward in all of the counties across the state. Thank you.
Thank you.
Good afternoon, Mr. Chair. Joshua Golka with the American Federation of State, County, and Municipal Employees, also here in support of the augmentation. We do also share the concerns from SEIU regarding both the workload study as well as the IT issues that you have mentioned. Thank you.
Thank you.
Good afternoon, Mr. Chair. Farrah McDade-Ting with the California State Association of Counties in strong support of the budget augmentation for county administration, as well as the proposed time study or work study. There were visits, as many have referenced, and everybody got a good idea of what the eligibility workers have to do, but now we want to do a more formal study, the administration as well. We think that'll be great, and what that will do will allow us to set the county medical administration funds at certain levels that will allow for some budget predictability for both the state and for counties. So we strongly support that. Thank you.
Thank you. So moving on to our item issue number 4, Dentical program. It says Ms. Cantwell. Once again, Ms. Cantwell. and others on your team.
Yeah, so I am having Renee Malo, our Deputy Director over Healthcare Benefits and Eligibility, in case you do have questions that I can't answer. She probably can answer them. So there were just really several questions that were posed in the agenda, so I'll just run through those fairly quickly. In terms of an update on improvements, we are obviously continuing to work on improving the program. Some of the things will be touched on in more detail in later questions with regards to outreach that we're doing both with beneficiaries and providers, the monitoring that we do in terms of utilization and provider participation, but also sort of the final thing really being the biggest investment and the biggest sort of work that we're doing right now really relates to the implementation of the waiver component, the $750 million incentive payment program over the next 5 years, which again provide more detail when I get to those questions. So we are continuing this work and really looking to meet some pretty strong targets on improving access to care and improving utilization in the dental program, particularly for children. With respect to the utilization numbers, in terms of the fee-for-service program, which serves most of our counties, we're a little under 51% of children utilizing services. That's not a great number. It's better than it was in the audit. The audit had us below 50%, so we've made some progress, but clearly a lot of work still to be had. One of the targets that we'll talk about in the waiver is an increase of that by 10 percentage points over the next 5 years, and we certainly think the waiver funding will help us do that. For our managed care program, which operates in Sacramento and Los Angeles, those numbers are lower. It's about 39%. And so again, a lot of work for us to continue to do there with our health plans, and we are doing that with them. So a lot of work still to be done, some slight improvement, but we definitely want to see those numbers come up, and how we're going to do that we'll talk about now. First, questions about how we monitor access. We actively monitor the program actually in several ways. We have beneficiary utilization measures that we look at, which includes things like annual dental visits, overall utilization of services, utilization of preventive services, continuity of care. We also track provider participation through provider to beneficiary ratios, the claims that we're seeing come in. We receive weekly updates on who's enrolling and disenrolling from a provider perspective in the program. We also do annual provider surveys that go into more detail on the capacity that we're seeing in our provider offices. So they ask things about what are the ages of the people that you can see, how many people can you see in the program, what language services do you have, what other special services do you have. So all of those things are ways that we monitor the program. Per statute, we do report on these measures annually, and that information is on our website. And then the question here also was just what are the challenges with monitoring a fee-for-service program? And just generally, and we've talked about this before, fee-for-service is not an organized delivery system. It's just a system of providers that is out there, but there's not a particular entity that's responsible for coordination of care or tracking continuity of care, things like that. So we're working with our Delta contractor, who's our fiscal intermediary, to figure out ways to improve the system so that we're tracking those things better and try to put in place things that will help beneficiaries access the services, including, making sure that there's people available to answer the phone to help them find an appointment, doing warm transfers actually to the dental office and actually talking with them on the phone with the office to get them scheduled for an appointment. One of the things that we did, and that is asked about here, is the outreach that we did as a result of the action in the 2014 budget. Under that outreach, we targeted 653 children between the ages of 0 to 3 who had not had a dental visit in the prior 12 months. We sent their parents and guardians a mailer that encouraged them and told them about sort of first tooth, first birthday to get in to see the dentist, and had other educational information. And then we followed that up with sort of an auto call that had a message about the same information. We've tracked the utilization of those kids that we targeted. Of that 653,000 beneficiaries, 104,000 of them utilized services after we did that outreach. So we had a 16% increase in utilization for that target population. So while, still there were a fair number that didn't utilize services, we actually were very happy to see even, that number of the 104,000 and really is helping us think about how do we do more things like that, where we can make sure people are aware of the services, make sure that they're aware of how to access them and provide them that education. So we'll be doing more of that. We also have plans within the waiver proposal to do some of that. And two other things that we did in 2015, we developed 2 different outreach plans with our contractor, Delta Dental. We did a outreach and education plan to improve access and utilization, and that includes informational notices to all new beneficiaries, calls and notices to existing beneficiaries about services, since again we saw some improvement when we did that to the targeted kids, as well as looking at improvements to the website and other things, again, making it easier for people to find the information that they need. We also have a provider outreach and utilization improvement plan that includes activities aimed at increasing provider participation as well as improving provider retention, and looking at what are some alternative ways we can provide dental services, including teledentistry, utilizing school-based health centers and other safety net clinics as a way to, again, provide more access points to services in this important program. The next question was about the adult restoration. So we did a partial restoration of the adult dental services in 2014 as a result of the act of the legislature. What we looked at then, so the benefit was eliminated in 2009. So right before the elimination, we had a little over 1 million adults who were using dental services. That was about 34% of the population at the time. We then looked at 14-15, which was the first full year after the restoration, the partial restoration of the services. While from a percentage standpoint, it was a lower number, so we have about 23% of adults at that time who were accessing services, so not as high as it was before the elimination, which was 34%. But because our population grew, the actual number of people getting services is higher. It's about 1.5 million adults. So about a 50% increase in the number of people accessing services compared to 2009, but a lower percentage because as a result of the expansion, our adult population has grown so significantly. So we'll continue to monitor that and see where that's going. We did anticipate it would take some time to get back up to those same levels, and obviously would like to see that even increase further. We want people getting in to see dentists. It is a preventive service and actually improves healthcare generally, so we want to see improvements overall in that utilization. And then the final thing I was asked to touch on relates to the waiver. There were a couple of questions. I'll sort of mush them together. So the way that the dental program in the waiver works, again, it's up to $750 million over the next 5 years. All of that money going to actual dental providers. It's available really in an incentive payment structure, so it's paying for outcomes, it's paying for actual changes in utilization. We've structured it in 4 different areas. So we have what we call domains. The first domain is focused entirely on increasing preventive service utilization for children. So it's targeting an idea. What we want to do over the next 5 years is increase that number, that 50% number, which is not where we want it to be, by 10 percentage points. So getting that up to 60% over the next 5 years. So it's a challenge to make that big of a change, but we certainly think that this money is going to help us get there. So this will be a statewide program. Every provider of dental services will automatically be eligible to receive this funding. And what we'll do is we will set for each individual provider, so the service office where they're providing the services, we'll look at their historical baseline information and set a predetermined target that they should meet in increasing the number of services they provide. If they meet that, they will receive an incentive payment in addition to just being paid for the service. Right now, we're targeting that the incentive payment would be a 75% of the rate. So essentially, a provider could earn up to 75% more funding for preventive services if they meet their predetermined target. The second domain is caries risk assessment and disease management. I always say this, I don't know why it's called caries and not just cavities, but I'm not a dentist. I'm sure there's makes sense to them. But this will be focused in pilot counties initially, and we're focusing on those counties where there's actually a higher utilization of restorative services versus preventive services. So not what you want to see. You want to see more preventive services. And so the intent here is to actually use this model that has a risk assessment mechanism. So there's a risk assessment done of the child, and then they're put into different risk categories, and then a treatment plan is developed based on that risk model. Dentists in this case will be required to opt in these counties if they want to participate, and there are certain requirements they'll have to meet in order to opt in. And then we'll be measuring how is this changing the services, how is it shifting services to preventive services, and the incentive payments will be earned based on actually completing the risk assessment and providing the additional services that are in the treatment plan. The third domain is focused on continuity of care. So just like in physical health, we want people to have a primary care dental provider that they continue to go to so that there's continuity, that there's someone who's looking out and making sure that they are getting services every year, as we all should be. And again, this will initially be focused in pilot counties, but looking to potentially expand that after the first year. So we're in the first year right now. But in those counties, all dental providers will be eligible to participate. There won't be an opt-in process. We will be looking at, for, again, each individual service location, are they seeing the same children in continuous periods with no gaps between years? And to the degree they are and meeting those targets, they will be eligible to receive additional funding for doing that beyond, again, just the payments for services that they're providing. And then the final area allows for up to 25% of the funding of the $750 million to be targeted at local dental pilot programs. So up to 15 of these programs can be approved through an application process that we're still developing. And local entities would be able to develop strategies focused on one of the three domains that we already talked about, and really looking at how to do those best in their communities. And so we'll be taking those applications and reviewing them, and that process is still being developed. The eligible entities are counties, tribes, Indian health programs, or UC or Cal State University campuses, and they would submit the applications and describe their target population and the activities that they would be undertaking. So overall, our goal here is to impact the dental program for children specifically, and we're targeting, again, the increasing utilization of preventive services, increasing provider participation, trying this new method of risk assessment, and increasing continuity of care. There will be an evaluation of the program that's required by the federal government, but in addition to that, we will be doing continuous monitoring of how is this impacting the utilization of services and what are we seeing so that we can continue to adjust if we need to, but really hope to see and believe that these types of programs can have an impact in a way that we haven't been able to have so far by having this infusion of dollars to the dental program. So with that, I will see if you have questions.
Thank you. Did you have something that you wanted to add?
Oh, no, she did a lovely job.
That sounded like I wish to associate myself with the remarks of my distinguished colleague. Well done. Well played. Thank you. I know we're going to have a hearing where we devote a significant amount of time to the issue of Denti-Cal, and I hope that when we have that conversation, we talk about access, 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 and that we have a very head-on, straight-on conversation about all the things that we think prevent access, whether it's rates, whether it's other barriers, training, availability of providers. I want everything to be on the table in that conversation. I do want to ask just about what we had this conversation last year. I think it was a pretty frank conversation that we need to do better, and I want to acknowledge some improvement, but obviously we just need to do better. And we talked about it last year. I'd like to just hear you talked about rates in LA, you talked about rates overall. Can you talk about rates in rural areas, whatever you can share with me?
So I don't know that off the top of my head, but we will get that to you. Certainly we know there are areas where there are more challenges, and in some cases that's because there aren't any dental providers, regardless of whether there's Medi-Cal. In some cases there may be one provider and they're not accepting Medi-Cal. But those are the areas we're focused on with Delta, on how do we improve that, but also how do we look at it? Are there things like teledentistry or school-based health centers that we can be relying on? And so, but we will get you the county numbers so that you can see the difference across the state.
That'll be great. And when we have the conversation, I want us to talk about how do we work through those barriers. We know that there are significant challenges in those areas, and I think you started to touch on alternative ways to deliver the services. I do want to hear about that. I look out and I see some constituents who live in my district who know that when I was on the school district, we actually built a state-of-the-art dental clinic in one of our elementary schools. It happens to be an elementary school that has the highest rate of poverty, has the highest rate of every social economic statistic that you don't want your community to have. But yet we get that kids can't learn when they're not healthy, if they've got pain, if they've got, health needs, oral health needs. And so, I want to hear about the alternative efforts, and I want to hear the blueprint for how this year is going to be different. We know that there are limits. We know that there aren't providers. But I want the narrative to be different. I want the narrative to be, this is what we're doing to change that narrative. And until we can have a conversation, a long-term conversation about changing rates, we're doing these things to make sure that in the meantime, children and families get access. And you mentioned, teledentistry. I know we'll talk about that. We do want to hear about what's your strategic plan for how we're going to move this forward. Okay. So I'm telegraphing for you right now all the things that I'm going to ask you this year, and so that you will know, and we can have a robust conversation that's focused on solutions.
Great.
Because we know who's waiting on the other end of that, our kids.
Yep.
Thank you.
Thank you.
Anything from finance?
Mr. Chair, Mary Second from Department of Finance. I also would just like to note, in addition to the significant investment in the waiver program, that the medical estimate actually has new funding totaling $860,000 total funds for beneficiary outreach and education. It's focused on counties with low utilization. So it is really the administration's focus to increase utilization.
Yep.
Fantastic.
Thanks.
Thank you. Anything from the LAO's office?
We don't have any issues to raise on this item, but staff have asked us to present a stakeholder proposal. The Western Center on Law and Poverty and the California Pan-Ethnic Health Network propose the restoration of the remaining dental benefits for adults that have yet to be restored. According to the agenda, the administration estimates the cost of this restoration would be $260 million total funds, of which $93 million would be general fund. This would include preventive, diagnostic, and restorative procedures, as well as root canals, laboratory processed crowns, periodontics, implants, and partial dentures.
Thank you. It's noted, and we will continue to review the proposal going forward. Thank you. Is there any public comment on this section?
Mr. Chair and Mr. Chair and staff. Greg Cook, representing Healthy Smiles, and Attorney Larry Hall of Los Angeles. I first want to commend your staff on a really good, thorough background paper and a good history of the program, and I think the staff report singles out the two issues that I want to share with you today. Number one, the audit that the state auditor conducted focused primarily on dental health care for children. There's a serious problem with older adults, and being one, perhaps I'm more emotionally involved than others might be. Very serious problem, in spite of the fact that the department reports an increase in the number of people participating in the Denti-Cal program, number of adults. We're finding, especially in skilled nursing facilities, a dramatic reduction. We're trying to sort out, is the reduction as a matter of cost because of the low reimbursement to the dentist, or is it part of the problem with the managed care? And we're trying to sort through what all that is. We ask for your help, and I'm delighted to hear that you're going to have another hearing, subsequent hearings, and that you will bring this issue forward. Like the department, we agree that preventative care is critically important, and you'll save a lot of money if you focus on the preventative care issue. Thank you for your attention to this. Look forward to working with the committee as you go forward.
Thank you.
Not going to repeat everything that Greg said, but I do want to commend the department for all their work on this, their dental transformative initiative, and we're very excited about their move forward to focus on delivering care in new and different ways at places where kids and people that need services, such as in nursing homes as well, are at. Did I even say who I am? I'm sorry, I'm Kathy
Please.
Dressler. Kathy Dressler from the Children's Partnership, and very big fans of the work that they've been doing on the waiver. And I think I'll just quit there. We'll look forward to your other dental hearing.
Thank you.
Good afternoon, Mr. Chair. I'm Brianna Pittman with the California Dental Association. Just want to echo the comments that have been made. Really appreciate the work of the department and the legislative focus on Denti-Cal and dental issues. We're really excited about the significant opportunity that the Waiver Dental Transformation Initiative provides to improve care for kids. We think that transparency transparency in the initiatives or in the incentives and the evaluation is going to be key for making sure that the program really does what we want it to do, which is increasing access for kids, improving health outcomes and the health status. And so we're looking forward to working with the department and with you guys on that to make sure that that's what we, that we see what we're looking for. And then on the adult benefit restoration, CDA strongly believes that all adults need to have access to comprehensive dental care, and our concern is just that the system we have right now has many problems. Low rates are obviously one of those. The waiver solely focuses on kids and doesn't provide any incentives for adults. So we, hope that we can't do one without the other, and we hope that we can find new ways to look at improving access for adults like we have in the waiver. Thank you.
Thank you.
Good afternoon. Kimberly Chen with the California Pan-Ethnic Health Network respectfully urge the committee to restore dental benefits for adults, and I won't repeat many of the comments, but I do want to note one thing about the lack of providers and what that means for communities of color. That lack of providers means that there are fewer providers who can provide culturally and linguistically appropriate care, and that has real consequences for utilization and for reducing health disparities. And as we've talked to communities around the state, we hear this very loudly, and I'll give one very specific example of a Southeast Asian community in San Diego when there was one gentleman who was very respected in the community providing Denti-Cal, I think the only one who could speak the community's language. When he retired, nearly most of the community stopped going because they didn't trust the other folks. They didn't speak the language. They couldn't relate to them. And so we're talking about providers and lack of providers. There's real direct consequences for health disparities for our most in-need communities. Thank you.
Thank you.
Linda Way with Western Center on Law and Poverty would just like to align our comments with all that has been stated, as well as appreciate the agendizing the full restoration of adult dental benefits, as we've heard from our legal aid advocates of the challenges adults still face in receiving gum treatment, which is critical to controlling blood sugar and diabetes, as well as the other adult dental benefits that have yet to be restored.
Thank you.
Michelle Stoll-Pravensky, Children's Defense Fund, California. I would align myself with previous comments and really appreciate the administration's work on improving dental access for children and the recognition that we need to do more if only 50% of our children are receiving preventative dental services, and also encouraged by the opportunity of looking into other programs that can improve access and make sure children are getting services, such as the California Children's Dental Disease Prevention Program, which was a really successful program that was cut in 2009 that provided dental services to elementary school students in schools. So looking at some creative and successful programs that can actually make sure children are getting these services. Thank you.
Thank you.
Hello, Chairman Thurman, folks. John Carvelli, Liberty Dental Plan. We're one of your 3 contracted dental plans with the Department of Healthcare Services in Sacramento and Los Angeles. Wanted to reassure you, sir, that we are going to be here at your hearings providing information on some initiatives that we're working on to increase encounters for kids, working with the department with Renee and Alani. There's going to be a school-based program this year we're doing through the Center of Oral Health and a primary care provider training program we're working on to try to get kids as they go for their well baby visits. So we'll come to the hearings and provide this information, and hopefully it'll be some good solutions to increase the quality of the program.
Thank you.
Thank you.
I'm encouraged that of the 653,000 some children who you did the letter mailing campaign to, over 100,000 availed themselves of the services. Yep. That makes me think that there are savings, because when we're being treated, we don't have longer term and deeper impacts. And I'd like to see us be using those savings to do more of that outreach. If that means getting dentists to go to places that they may not normally get to and doing service delivery in ways that are non-traditional. These are the kinds of things that I'll be asking to hear, that we are reinvesting the savings from where we have had some success to help us have more success, because we know it will save us even more both in the health of our patients and in reduced cost when our patients are seeing a dentist regularly. Thank you. We have one final panel. Again, we invite you, Ms. Cantwell, and your team. Thank you all to update us, give us a high-level overview on the technical trailer bill on drug rebates.
Sure, and just one thing to note, we did notify the consultant earlier today that we have some additional technical changes to the trailer bill that we'll be providing. Again, they're technical, but apologize that we had to do that after it was already on the agenda. So just to step back, in 2014, SB 870 trailer bill was enacted to allow the department to collect supplemental drug rebates on non-COES managed care drug utilization. Prior to that, we could only collect supplemental drug rebates on fee-for-service and COES drug utilization. At the time, we essentially were targeting, the way that it works is that if we pay our managed care plans a separate capitation payment for a particular class of drugs, those classes of drugs we could seek supplemental drug rebate agreements with the manufacturers. So essentially the only class of drugs we're doing that type of payment for right now are hepatitis C drugs, but we are looking at what other types of drugs might make sense to do that for. So the intent was always that we have this ability to do it for a class of drugs, and the technical changes that we're proposing will actually let us do that with respect to blood factor, HIV and AIDS drugs, and cancer drugs, to have the rebates be for that classification of drugs. And so that's really what this is doing, is cleaning up that, as well as correcting some non-sequential numbering and other sort of very, very minor things, but really to have the intent of what the language was in 2014 be what the language is doing, and that's, again, to collect supplemental drug rebates for across all of our managed care programs and not just fee-for-service and our COES programs. Our concern here is without this trailer bill, there could be some misinterpretation of the language, and we could be at risk of losing our ability to collect those supplemental drug rebates.
Thank you. Did you have anything that you wish to add? Thank you. Anything from finance? Anything from the LEO's office? Is there any public comment on this item? Going once. Seeing no public comment on this item, let me thank our presenters for your testimony. Thank you. Thanks. And as this is our final item, I want to thank all of our presenters today. And thank all of you who are here and for your interest in health and human service. We'll do it again next week. This meeting is adjourned. Thank you. Thank you.